This has been about 2 days of face pain, dental pain. You said you basically have some swelling. We're doing a little temporary numbing right now as we're getting ready to do a local injection. We have our dentist working with us here today. So you're okay with this video being made?
Yes, sir.
All right.
So you have your upper teeth. It consists of 3 different major nerves. The PSA, which is the posterior superior alveolar nerve. Then you got the MSA, the middle superior, and then the ASA. The PSA, what you want to do is you want to get behind the second molar, and then take the needle and infiltrate the vestibule about 7 millimeters up in there, and then place the injection. That will block the nerve. Then you have the MSA, same thing, vestibule 7 millimeters. Anterior is above the canine, apex of the canine, about 7 millimeters. You want to inject in there. However, for the maxilla, the bone is very porous, and so local anesthetic penetrates very well into the bone. And so, matter of fact, most dentists just all they ever do is infiltrate the tooth that is bothering the patient.
Yeah, when you're up on the maxilla.
Correct.
Otherwise, on the mandible, you're doing the inferior alveolar nerve blocks.
That's correct.
Okay.
So the bone in the mandible is more dense, so anesthetic won't penetrate it. There is an anesthetic septicane that will, but you guys don't carry it in the hospital.
Okay.
So what you have to do for that one is, I'll just show that one since we're not giving that injection. I'm just going to leave this cap on, okay? So I'm not actually going to give you an injection. Let me get you to open up for me. What you want to do is you want to just palpate. You'll feel the ramus, and you're just going to push your finger straight back in there, and you'll feel a little divot. And what you're going to do is you're going to take the needle, come across from the second premolar on the opposite side, and then you're going to stick the needle in and advance it. And if you're using one of these long needles, these yellow needles, you're going to take it about 3/4 of the way all the way in, but you're going to bring it in across you'll actually nick the bone. You'll feel it. Once you feel the bone, because every person is a little bit different, once you feel the bone, you might have to manipulate the needle while you still leave it in the mouth and advance a little bit further back.
Okay.
And then what I do is I deposit about...
Are you shooting medial to the bone?
Medial to the bone, correct.
Right.
Correct. And so what I do is normally deposit about a half a carpule, and then as I'm pulling back, I just keep dumping a little bit more anesthetic. And the reason why is this actually gets the inferior alveolar nerve. And as you pull back, you're going to get the lingual. The lingual is actually before that one. But what I do is I actually give a little bit as I'm advancing a little bit too.
Okay.
But then when I pull back, I start just depositing it as I pull back like that. And that usually gets the lingual nerve. It's a pretty easy one to get. All the teeth, all the way down to the central incisor on the same side. However, the whole buccal mucosa still feels sensation.
Okay.
So what you want to do is give the long buccal injection.
Okay.
And you just want to come right to the outside of the ramus here, and you're going to advance it in about 7 millimeters again.
Okay.
And deposit the anesthetic. You got to be on the lateral of the bone. Lateral
and that's the long buccal.
That's the long buccal.
Got it.
And that'll be good enough for him. As far as the upper, every time you infiltrate, it will get the mucosa on the outside too. So only in the mandible do you got to do that. Rarely, let's say just hypothetically, you can't get a patient numb. Sometimes it's the myohyoid. Very rarely, it's like 2% of patients have an innervation from the myohyoid. You're just going to take the needle, drop it straight down to the palate. Obviously, you're going to aspirate to see if you got a positive aspiration, and then deposit a little anesthetic.
Okay. All right.
So we'll demonstrate what I'm going to give to him is an MSA, because that's where the tooth is broken. If you can, you could bend the needle slightly like this, just to get the right angle. Not too far. I'm only bending it because I'm not burying the needle to the hub.
Okay.
That way, just in case it does break off, I can still grab it and pull it out. But I'm only going to take it in about this far.
Okay.
So, and just a little pinch, it won't be bad. See where his tooth is broken? That's actually a second premolar. That's where you want to block the MSA. The buccal vestibule is right there. Can you see it right there? Let's see. Hand out of the way. All right, I'm going to advance a little bit. I give a little bit as I go. There's no major arteries right here. When you do the PSA, there is a lot of major arteries that run through there. So you do need to aspirate. Once I got it in about this far, I'm going to push back. No positive aspiration. And deposit the anesthetic. And if you like your patient, what you'll do is you'll go in with the lidocaine first, because it's really fast acting.
Okay.
Other than carbocaine is the fastest. If you come in with lidocaine, you'll get it numb faster.
Okay.
Then you're going to come back with Marcaine, which is bupivacaine, and it is a longer duration, but it takes much longer to set in. So once he's numb in that area, I'm going to come back with bupivacaine and give him a block with that.
Okay. All right. Is it starting to numb up for you?
It takes about 7 minutes for lidocaine, but usually people start feeling it within about 3 minutes or so.
Now, we've already given you a couple Percocets. Your pain was 11 on a scale of 10 when it came in. Now what is it?
Actually, it's about an 8 now, but I'm starting not feeling anything.
You'll start getting heavy here. When I give you this second injection, this PSA, about 2 minutes after that, it'll kick in. So this is the PSA. This one you got to get a little bit further back for. So I'm going to take my mirror. This might actually help.
Okay.
Open up for me. I'm just going to get back here.
So this is your PSA block.
That is correct. He's really swollen, so it's hard to push the cheek out. But I'm going to take it up. I'm going to aspirate because there's
What's your landmarks for the PSA?
It's going to be just posterior to the second molar in the buccal vestibule. The maxillary artery runs right through here, so you most of the time you do get a positive aspiration. And I don't really follow the book because they always say use half a carpule, quarter carpule. I always just use the whole thing. The toxicity of lidocaine is so minimal that I always give a carpule every time I infiltrate. So.
Okay. What were you saying?
I would say I can't feel it now.
So all pain.
So it took about 4 minutes or so.
The pain's gone now. Good.
This will give you. Now this is a good keynote to actually make.
Okay.
According to research, Marcaine has a duration of about 4 hours of anesthetic effect.
Okay.
However, if you block the nerves, so not infiltrate, but you actually go to the nerves and block the nerves with Marcaine, you can actually get 24 to 48 hours analgesic effect. So it won't be numb, but supposedly
the pain will be reduced.
Exactly. Correct.
Okay. Very good. Very good.
So anytime we do a major surgery, whenever we're about to walk the patient out the door, we always block with Marcaine, and that will give them plenty of time to get to their
drugstore.
Exactly.
Yep.
Let's see here. All right, so just the same. Can we see here?
Yeah.
Good. It's going to infiltrate the vestibule.
Now, which block are we doing now?
This is the
PSA?
This is the MSA.
MSA.
It's adjacent to the second premolar.
Okay.
And with Marcaine, because I already gave the lidocaine, I usually give a half carpule.
Okay.
And then I'll take the other half back here. Yeah, he's doing good. He's got a high pain tolerance too. He didn't jump the first time I gave him an injection. The MSA and the ASA, you never really, you should always aspirate, but there's no major artery back there.
Okay.
PSA, you'll come back about 50% of the time with a positive aspiration. So, and if you do get a positive aspiration, all you need to do is deposit a little bit of the anesthetic because there's epinephrine in it, so it'll cause vasoconstriction and prevent a hematoma. And then you're going to pull out of the vein this time, and then recheck your aspiration, and then deposit the whole anesthetic.
Good. Excellent.